Before I start, I want to congratulate the local organizing committee for organizing an outstanding symposium that spans over 8 countries. This is a unique and bold undertaking, and participation by all of you from different countries is a testament to its success. I was asked by the organizing committee to talk about the roles and responsibilities of professionals in radiation therapy. In order to understand roles of various professionals in radiation therapy, we need to understand what a radiation therapy process looks like. This slide shows a typical radiation treatment process for external beam radiation therapy. After a decision is made that a patient will undergo radiation treatment, the patient goes through CT simulation, structure segmentation, treatment planning and evaluation, file transfer and management, and the patient then comes for treatment with the patient on the table. We do position verification and then deliver the treatment. In the audience, I believe we all are radiotherapy professionals, and we are very familiar with this process. The message that I wanted to get across in this slide is that you can see that all these steps are linked to each other like a chain. We know that a chain is as strong as its weakest links. If any one of these links is broken, then the result is that the patient will receive suboptimal treatment. Furthermore, each of these steps have different professionals and they're involved in the care of the patient. So RT, or radiation therapy, is truly a multidisciplinary approach. We all know the standard roles and responsibilities of various professionals in radiation therapy. For me to talk about that will be a very dry and boring presentation. So I decided to emphasize and talk about a few items that I've learned to be very valuable in my career. I believe these are unspoken roles and responsibilities of all of us, the few bullet points that I have shown on these slides. Adherence to each of these creates a culture of safety, a workplace that everyone dreams of and wants to come to work to. And that in the end results in the best quality of care for our patients. So this is the theme of my presentation, and I'm going to talk about most of these, all of these actually. So what does a radiation oncology team looks like? The multidisciplinary radiation oncology team consists of radiation oncologists, medical physicists, medical dosimetrists. Some countries may not have medical dosimetrists, radiation therapists, oncology nurses, and other professionals. These folks work very closely to each other to ensure that patients are receiving the highest quality of treatment. So this is truly a multidisciplinary team-based approach where all these different professionals from these different disciplines work together. So yes, it's a team-based approach. It is important to recognize that each radiation oncology team member has a different but overlapping role. Patients will receive the best care when the entire radiation oncology team work together as a team rather than in isolation. It is very important to adhere to standard work processes because non-standard work processes in a rushed environment can lead to errors. And I'm going to discuss this with a couple of events. This is an event that happened in New York. You see here, this is Scott Jerome's part. He was receiving, he's a head and neck cancer patient and was receiving IMRT treatment. In the middle of the treatment, the physician decided to tweak the treatment plan to spare the teeth. And the physician was rushing and pushing. Under pressure, The physicist developed a plan and transferred the incorrect plan to the treatment machine. The therapist used this incorrect plan to treat Scott Jerome Spark. He received 13 gray in 3 fractions. On the hospital floor, he was complaining about pain. The nurses who were caring for him did not pay attention, and neither did the attending physicians. Scott died from this overdose of radiation. Here is another example. Here is, you see, Miss John Charles with her family. She's in the middle. She's a breast cancer patient, and she was over-radiated for 27 days. The plan called for a wedge to be placed in the field, but it was not in the field when she was treated. This resulted in her death. So you see that when standardized processes and appropriate quality management procedures are not put in place, then this can lead to catastrophic deaths. So the development of standardized processes, quality management program, and communication and adherence to them are our key responsibilities. We need to implement them in our clinical practice. So what do I mean when I talk about development of standardized work processes? So let me illustrate this with an example. Suppose you are planning to start a 3D conformal radiation therapy treatment in your clinic. So what you do is you put that multidisciplinary team, the radiation oncology team, radiation oncologist, physicist, therapist, nurses, IT personnel if needed. You put them all together on the same table and ask them to develop a process map of the treatment process from the time the patient will enter the radiation oncology department till the time patient will end the radiation treatment. Every step of the way, every point that the patient touches, develop that process. That is the process map. And let me show that as an example. Here you see on the slide along the center, there's an arrow that goes from the left to the right. All the way to the left is patient enters the radiation oncology department, and all the way to the right, patient finishes treatment. So in your example of 3D conformal radiation therapy, when the patient first enters the radiation oncology department, what happens is patient sees the physician for a consult. Then if a decision is made to treat, we go through CT simulation, treatment planning, plan checks, imaging, and then treatment delivery. We talked about that. And let me call each of these as a sub-process. And many things happen at each of the sub-processes that are unique to that sub-process. For example, at consult, the physician will talk to the patient and look at the patient's history and physical and get patient's medical history and other relevant information. At the CT simulation stage, the therapists will create an immobilization, put the patient on immobilization, put the patient on the table, do image acquisition, and do other things. So at each of these sub-processes, planning, plan check, imaging, treatment, there are many different steps that the patient goes through as patient undertakes the journey. And each of these steps, everything at each of these steps have to be executed just right. And if it's not executed right, the patient will receive suboptimal treatment, and the severity can be very bad depending on the nature of the problem that occurs at each of those steps. So when you sit around the table with all these professionals, everybody asks the questions, what can go wrong at each of these steps, and what kind of quality control do you have put in place? If there is a weaker link at any of the steps, you put an appropriate quality control measure so that failure does not occur. And the beauty of this is that you have around the table all the professionals who are working together to develop this process, who knows more for CT simulation and treatment delivery than the therapist, who knows more about treatment planning than the physicist, who knows more about imaging, the therapist and the physicist together. So when all these professionals sit around the table, they start to appreciate um, what everyone else does. Okay, and so the respect for each other grows. You care for each other, and a camaraderie grows. So this is an important quality management process whereby you pull the whole team together. It's a team-based approach. AAPM has published a task group. You see the reference on the screen here. It's called the AAPM Task Group 100. It just got published a few years ago. And in this task group, it recommends that one adopts this approach for quality management program in every radiation oncology department. So in working together, everyone should be respected, irrespective of what they do as a team member. They should be supported, provide the necessary tools, and we have to help them to develop, in their career job. They should be appreciated, and they should be empowered. And I'll talk about this later. And remember, my topic was to talk about the responsibilities and roles of the radiation oncologist and the professionals. I thought I should at least show a few one slide for each of those professionals. We know that some of the responsibilities of the radiation oncologist are to delineate the target volume and the organs at risk, write the prescription dose, and define the dose constraints that correspond to the standard of care, acceptable standard of care. Review the critical structures outlined by the dosimetrists and physicists. I want to emphasize that it is critical and very important that the radiation oncologists draw the clinical target volume, no one else, because they are the ones who are trained to look at the clinical side of it. Then the radiation oncologist performs evaluation and approve a treatment plan for implementation, reviews all implementation and verification, participate in peer review of the target volume definition and treatment plan, communicate with other radiotherapy treatment members. Communication, that's critical. The medical physicists are essentially jack of all trades. They establish connectivity with all the different disciplines. They also do many jobs, and here are just a few list of them. When you buy a new linear accelerator or an equipment, they provide guidance on what kind of equipment to purchase. After a linear accelerator is purchased, they do the acceptance testing and commissioning for the LINAC and the treatment planning system. They design and implement a high quality management program, taking into consideration the recommendations of the national and international guidelines. They design and implement an immobilization system. In many countries around the world, they do the treatment planning. They perform QA review of the treatment plans when someone else generates those treatment plans. They participate in peer review of treatment plans. They communicate with the other team members. Communication, remember. And they are also considered as the safety czar in almost all the radiation oncology departments around the world. Therapists also have many responsibilities, and here I've listed a few. They are involved in the CT simulation. They participate in the design and implementation of the immobilization and positioning systems. They clearly understand each treatment plan. They are involved in the delivery of the radiation. They perform a quick review of all treatment parameters, the plan setup and portal images. They closely monitor treatment setup and deliver treatment. They're responsible for ensuring correct treatment delivery and, of course, communication with the rest of the team members. IAEA published a tech talk number 1588 in 2007, where it enumerated or described the responsibilities of all the different professionals, and it is shown on the right. I'm afraid I don't know that you can see it all. Basically, from the top box, it shows that patient assessment is done, and the decision to treat with curative radiation therapy, and then all the way to the bottom, if the patient is decided to go under radiation treatment, all the lowest box in the bottom is treatment delivery. On the right are the different professionals who are responsible for the different activities that are shown on the left. For example, the top box On the left shows the patient assessment, decision to treat with curative radiation therapy. And the folks who are responsible for this are radiation oncologists, radiologists, surgical oncologists. In the middle, treatment planning. The professionals involved are medical physicists, dosimetrists, radiation oncologists. Verification of position and beam placement and beam delivery, it's the radiation therapists who are responsible for that. And physicist or radiation oncologist may attend the first treatment. Astro came up with also a description of the roles and responsibilities of the clinical team, and this is given as a in the table here. The first column gives you all the different parameters that different professionals are expected to perform, and all the other columns on the right are the radiation oncologist, physicist, dosimetrist, therapist, all the different professionals. And the cross represents that those are the activities that each of these professionals are responsible for. For example, patient positioning and image acquisition, all the 4 boxes, oncologist, physician, dosimetrist, therapist, they're all checked. That means they're all responsible for this. Dose volume constraints, only radiation oncologist, physician, and the dosimetrist are responsible for this. And weekly evaluation, all the disciplines, the oncologist, physicist, dosimetrist, radiation therapist, any non-physician providers such as nutritionist, oncology nurse, they all are involved. So I started my presentation talking about the theme of the presentation being empowerment and some of the other bullet points. And I said that I'll spend a little more time talking about empowerment. To discuss that, let me bring you the concept of power distance index. What is power distance index? It is the extent to which the less powerful members of institutions and organizations within a country expect and accept that power is distributed unequally. Okay, so it varies from country to country and culture to culture. IBM actually performed a survey decades ago where they asked a question. In your experience, does the following problem occur? Employees being afraid to express disagreement with their managers. In other words, will you disagree with your manager, who you report to? Will you be afraid to disagree with them? And here is some of the results that we got. The numbers, the higher the numbers, the more it's a reflection that the employees are afraid to disagree with their managers. In Malaysia, 104, UK, 35, US, 40, Mexico, 81. So this is a cultural problem, and it happens all over the world. So why is this relevant to safety, quality, and patient care? If the environment is such that we are afraid to question our colleagues, our managers, our superiors, then errors are more likely to slip through with potentially serious consequences. And let me illustrate that with an example here. You all may have heard this or remember there's an accident that happened, a Korean airline, ASEAN Airlines, that crashed at San Francisco International Airport. FAA did a lot of investigation, and after everything that they tried to find the cause for this, they actually pointed it towards the culture, the cultural practice. In Korean culture, like many in SAARC countries, we speak to our elders and superiors in a very honorable way. We do not disagree with them. In this crash, the captain was making an error. The co-captain knew that the captain is making the error, but because of that cultural barrier, you do not question your superior. The co-captain did not question the captain, which resulted in the crash. So the point is, in our discipline in radiation therapy, there is a cultural hierarchy that exists everywhere, particularly in low and middle income countries, where a therapist, for example, will be afraid to challenge or question a radiation oncologist or a physicist, or a physicist will be afraid to challenge a physician if in their judgment they see that the physician has made a mistake that will cause harm to the patient. They'll be afraid to do that. But as you can see from this plane crash example, such barrier, the in different culture, can lead to catastrophic events, and in the end, our patients are the patients who suffer from this. So I think it is critically important that we empower every professional who are involved in the care for our patients. We empower them to stop a treatment. If in their judgment, they think that a given action is going to harm a patient, they can stop the treatment and they can respectfully disagree with their superiors. And I'll urge each of you to really try to implement this in your clinic if this power distance index that exists in your clinic. So the take-home message from my presentation is empowerment, communication, respect, support, appreciation. These are all unspoken responsibilities of all of us in our discipline. And I'll ask each of you to please try to ensure that you implement this in your clinic, in addition to the routine responsibilities that all these different standards organizations tell that we're supposed to do. With that, thank you very much.